a good question, because on the face of it, paediatric oncology looks pretty well sorted out. It's very rare. Only 1 in 600 children get any form of malignancy by the time they're 15. It's already coordinated by specialised centres, both for children and for teenagers. The survival rates are pretty good. 80% of children who are diagnosed with malignancy will be cured, and that's getting better by about 10% per decade. So it all looks as if it's pretty nicely done. But the difficulty is that in diseases like acute lymphoblastic leukemia, at least as many children die of the treatment as they do of the disease. So that needs a look. And there's the perception amongst people in the field that if you look at children who do less well, who've got relapse disease, some of them go through multiple rounds of therapy where the intent of that therapy really isn't clear.
Well, the National Confidential Inquiry into Patient Outcome and Death has a strong track record in reviewing pathways of care and making recommendations to allow clinicians to further improve patient outcome. Over 32 years, it's published 49 reports, and its strength is it uses everyday practicing clinicians to both design and review the study. We took a population of patients who were 24 years and under and who were within 60 days of their last treatment with systemic anti-cancer therapy, and we looked at those that sadly died or were admitted unexpectedly to intensive care. We sent clinical questionnaires to clinicians who prescribed the last protocol of systemic anti-cancer therapy, to clinicians who were responsible for the care of the patient in their last admission to hospital, and we sent organisational questionnaires to the hospitals, looking particularly at protocols and policies in place. We asked reviewers who were representatives of all the professions that will have been involved with the care of these patients, so doctors, pharmacists, radiotherapists, and we asked them to review the patient notes and grade the quality of care that they felt that individual patient had received during their stay in hospital.
Well, it ended up, unsurprisingly, as being a high-risk population. Over 60% of them had had a previous protocol of therapy, and half of them were patients with relapse disease. Well, there were difficulties, and it was at the speed at which the data came in. The study was done in between 2014 and 2016, so that's before it became mandatory to have electronic prescribing, which clearly helps with the identification of patients. But at that stage, even big trusts found it difficult to identify which patients they'd actually given chemotherapy to during the study period. Yeah, relapse is a very difficult time for families and clinicians. When you're first diagnosed, the aim is to cure the patient, and really discussions about whether the toxicity exceeds the benefits aren't really part of that discussion at all. When you've relapsed, the discussions are much more nuanced, and it's absolutely imperative that the potential benefits of therapy are really well discussed with the families, and that the toxicity of the therapy is also very frankly discussed with the families. Now, what was surprising was around a third of these difficult cases were not discussed in a multidisciplinary team meeting at any stage during the choice of the protocol. And as these are the most difficult decisions clinicians make, that was a surprise finding. It's really important to be frank about toxicity. In this study, 22% of patients died or went to ITU as a direct result of the treatment, and the treatment gave substantial toxicity in a further 25%. So if you're going to give chemotherapy, you have to make sure that the patient is fit enough to receive it, and it's likely to do them some good. Now, that was really well done on patients on clinical trials, but only 18% of patients on this study were on a clinical trial. So are you fit enough? Well, the toxicity assessments, like checking a full blood count, were done in almost everybody. But actually looking at the patient holistically and saying, in general, how are they? That was only done in under half.
Well, toxicities that cause concern, the principal of those is neutropenic sepsis. These patients have compromised immune systems, therefore when they're exposed to sepsis in the face of poor white cell function, it's serious. And what we found was that 25% of patients admitted had sepsis, and 40% of the patients showed symptoms of sepsis during their admission. Now, unfortunately, half the patients that had sepsis did not get antibiotics within 1 hour of the diagnosis of sepsis. Now, NCEPOD has published a report on sepsis in which it was emphasised how important it is to get antibiotics into these patients quickly. And to compound that, we were concerned that patients were not being reviewed by senior clinicians within the stated guideline of 14 hours as laid down by Royal Colleges. In 31 out of 68 patients, there was no evidence that any discussion whatsoever had taken place between the patients, their relatives, the critical care physicians, the clinicians looking after them on the wards, as to the appropriateness of an admission to a critical care area, and B, whether there should be any ceilings to treatment during their admission to critical care. We found that in only half the cases was there any evidence of audit of toxicity related to SACT, and more importantly, that only half the deaths were reviewed following the treatment of these patients. In 58.6% of patients, the reviewers found that the care these patients received was good. In the remaining cases, it was found that there would be room for improvement in both clinical and organisational factors throughout the patient's pathway.
Well, there's 4 recommendations and 3 of them are linked and are around communication. So the care of a patient must be discussed in a multidisciplinary team meeting. When discussing the care with the patient and family, it has to be a frank discussion. What's the potential benefit of the treatment? What are the toxicities? And that has to be reflected in the consent form, which really ought to give numbers around the potential benefit and mention all the risks of toxicity, including the risk of a toxic death.
And the final recommendation is around the review of these patients by senior clinicians. The Royal Colleges recommend that these sick patients are seen in a timely fashion by senior clinicians, and we would urge all clinicians involved in the treatment of these patients to understand that and recognise its benefit.